Welcome to the podcast of Hemisphere, the official journal of the European Hematology Association. Hemisphere's podcast presents insightful, expert discussions about recent hematology publications. We hope you enjoy.
Welcome to this episode of the Hemisphere podcast. My name is Stephen Hibbs and I'm a haematologist and clinical research fellow based at Queen Mary University of London, and I'm one of the scientific editors for Hemisphere. So today I'm joined by both a haematologist and a neurologist to discuss a condition that straddles several different specialties. Dr. Shirley Dessar is a consultant haematologist and honorary associate professor based at University College London Hospital. And Michael Lunn is Professor of Clinical Neurology based at University College London and the National Hospital for Neurology at Queen Square. They published a Hemisphere paper last year entitled Comprehensive Diagnosis and Management of POEMS. And in this podcast, we will focus on some of the diagnostic challenges that POEMS presents, how you discuss a complex condition like this in simple terms, what challenges and opportunities cross-specialty working brings, and some of the uncertainties about the condition and the ways forward. So the first question I want to ask you both, and I'll start with Shirley, is how did you both end up being interested in such a rare condition like this?
Yes, thank you. So my background in hematology is myeloma based, and during my registrar training and subsequently when I became a consultant, I was in a myeloma clinic. Our proximity to Queen Square, having it in the same trust, meant that we already had some established collaborations, and my supervisor at the time and our colleague, Professor Kui Yong, was in communication with Professor Mary Riley at Queen Square, and there was the commencement of a joint clinic to look at some of these patients. So that's how it started. But I think once Mike Lunn joined the team as a consultant on his side, we got into the clinic in a more sort of systematic fashion. It became more frequent, more regular. And I think we both came to it from our different angles, but it is a fascinating disease to start with. It is multisystemic, and my own personal approach journey is although I'm a hematologist, I do love the physicianly aspect of hematology. You have to look at the patient as a whole. You have to understand all the nuances of the condition. And I've always valued working very closely with Mike because I see medicine through a different lens as well as my own. So I think it's been an organic process. It's grown, but I think POEMS is such a unique and fascinating condition, and one in which you can see amazing change if you pick the diagnosis up early and treat effectively. So that I think is really the way I got in.
How about you, Mike?
Yeah, I think that's very similar, really, for me. It was this collaborative working that was always great fun that I took over from Mary Riley, and in that joint clinic, I used to sit in that clinic occasionally as a more junior doctor, and was fascinated by the complexity of some of the patients. But I suppose there were when I got my consultant job and had to start making my own competent decisions. The challenging patients are always the most fun. They're the most intellectually difficult, and they're most satisfying to solve. And there's one particular patient who I remember extremely well, who was young but very disabled over a short period of time, who had been through more than one other neurology centre, and then came to us. And we perhaps always have, to an extent, the benefit of retrospect and looking at everything else that everybody's done and failed at, in a way, which I suppose puts us at a bit of an advantage. It is much more difficult right at the beginning, and yet this patient was very complex, with systemic disease, with all sorts of interesting things in internal organs and skin and nerves, and in some ways it felt like a very wholesome disease that didn't look very mysterious from the outside, but actually when you looked into it, you thought, how can all these things happen together? So it became a fascinating case in its own right, and it was solved fairly straightforwardly, and as it turned out, with a bit of additional thought. And then the patient was then fixed, and we now see him from being totally disabled. He still comes back to the clinic, and it's enormously satisfying seeing him nearly 20 years later now, being normal. But it was then a few other very similar cases. Think, oh, I've seen this before, and nobody else has seen it before because it's so rare. And actually, now that we see them, many of these cases, despite their variability and differences, actually they look largely the same as one another. And so it's enormously satisfying to be able to put all the pieces of the jigsaw together, recognize all the different aspects of it, and say, okay, well, that is what this is, and then have a treatable condition that make people get better from. So it's a very satisfying place to be. Of course, it's only one of the many diseases that we do deal with, but as we've developed a reputation, we've seen more and more patients. We're able to give them more and more comprehensive therapy. We're extremely lucky being in a centre where we can go from the beginning to the end, from initial symptomatology through the diagnosis, through complex treatment to rehabilitation, and hopefully back to normal life. So it feels like a very wholesome place to be, and I think we both enjoy it, and we enjoy each other's intellect and company at the same time. So
it's great. So both of you actually alluded to the sort of, well, both the importance and the challenges of diagnosis. So Joe, you mentioned the sort of big if people have been diagnosed early enough in terms of the sort of recovery that can be expected. And Mike, on a few times you mentioned just how challenging this can be, particularly if you don't see it very often. So I was struck in your paper actually by that message of just how important and how common delayed diagnosis or misdiagnosis is. Mike, starting with you, would you be able to kind of just say a little bit about what a journey to diagnosis might look like for a patient with POEMS, and the different steps at which it might either be missed or caught?
Yeah, so sadly, the diagnosis is often slow and perhaps delayed. One of the interesting features of some of the data we've produced is that the average timed diagnosis was about 17 months, which is quite a long time. That is now getting shorter. The other thing that we discovered was about 50% of patients made their own diagnosis, at least had suggested it. And quite often it was rebuffed by the clinician to whom it was suggested. And that's because those patients, we've all in medicine become very focused on one disease or one area. We've become super specialists. And so the patient journey, if the patient starts off with a neuropathy and numb, tingly feet or some pain, if it's painful, they might end up in a rheumatologist straight away, perhaps, or and then they're off down a wrong path. They might end up at a neurologist, but the neurologist has to think more broadly than the neuropathy. They might appear randomly with a hematological problem and almost no neuropathy at all. And because the P of POEMS is polyneuropathy, the hematologist doesn't necessarily immediately think about it if the patient doesn't complain of the polyneuropathy. So they're at the early stage where symptoms are mild, you can be tripped up if you don't start thinking more broadly. We did then publish some, if the person gets to a neurologist, we published a paper that suggested if you have a conduction slowing neuropathy, a demyelinating neuropathy, then you can really rapidly get to a diagnosis by doing a serum immunofixation. That's a very simple test on the blood, and measuring VEGF, a vascular endothelial growth factor, both of which only cost about £40 each, but can be used within a sort of series of blood tests that you would be using in your conduction slowing neuropathy blood set. And that would give you the diagnosis right at the beginning, because there's very little else that produces those, an abnormal lambda light chain paraprotein and a very high VEGF in the context of a conduction slowing neuropathy. So that's just that's a change in perhaps diagnostic strategy that we need to try and introduce to neurologists because they can now do a VEGF. And if neurologists can access that, which should be fairly easy, then they can make that leap early on without going through several other stages. I think in the perhaps I won't speak for Shirley's side of things in hematology and where the diagnosis gets missed there, but I think probably if people miss those steps, they then get treated for a conduction slowing neuropathy, because a neurophysiologist might say, well, this is conduction slowing, it must be CIDP, and the patient gets steroids, which then squash the VEGF, and then it becomes more difficult to find, or they get lots of IVIG, and it takes several cycles at 6 weeks each to work out they haven't responded, so it might be 6 months before they haven't responded, then somebody thinks again. So I think the message is, for my neurology colleagues, and perhaps my hematology colleagues referring to neurology, is if you've got a neuropathy and it's a conduction slowing neuropathy, then just think, could this be a bit more complicated than I think it is, and do those tests. And I mean, again, going back to the retrospect thing, we have the advantage by the time we see patients, I have to say, more like 6 months on now than 17 months on. But usually many of the other features are visible. There's some ankle swelling in the conduction of ankle swelling in the context of a neuropathy. For a 40-year-old, for instance, would be really unusual. Not many 40-year-olds have ankle swelling, so that should ring a bell. And if you take somebody's shirt off, which many clinicians fail to do, then you might find the classical skin lesions. You have to look at the fingernails. This is something that we're all taught in MRCP. Are those fingernails normal or abnormal? Is the color of the toes normal, or is it a bit acrocyanotic? We have to take the socks off. So it's something that people perhaps have lost the skills of doing, or they're too busy to do in a busy clinic. But it is just thinking, I just need to go that extra step, take the socks off, take the shirt off, look for the exciting features that give me all the bits of the jigsaw puzzle. Ping, got it. So it's some of it is just fun general medicine, really. So all of those things can trip you up. If you think about the beginning, in many respects, it doesn't matter if you sort of overmake the diagnosis. If you think about it and you can reject it, in a way, it's better than if you haven't thought about it and you've missed it. So I guess that's how I think things get missed or get picked up. The other thing that makes people thankfully get to the diagnosis more quickly is being able to tell people about the diagnosis like this, and educate people. And we do try and give as many talks as we can. We publish useful papers like this one that help people in their clinic that they can reference whenever they want to. Patient information events. It does get, the information gets around so that it gets in people's psyche and they do think about it.
Brilliant. So Shirley, what about people coming through the hematology clinic, or kind of, I guess, where there's the monoclonal gammopathy's been picked up, but perhaps the other features haven't yet been noticed? What might a journey look like through the hematology clinic?
Yeah, so I think what Mike and I found over the years is that quite often POEMS is hidden in plain sight, actually. And because we've seen many, many patients over many years, we have just become adept at spotting the features, and so we, in publishing our paper, our various papers, but most recently the comprehensive diagnosis paper, we were hoping to just draw out those features so that people spot them. And I think in hematological circles, I think the monoclonal gammopathy, which is lambda restricted primarily, almost all are lambda restricted, with myeloproliferation, so people have a high hemoglobin and high platelets, one should really try and think about this. Now, I think, as Mike alluded to, modern medicine is sort of really disadvantages the POEMS patient because people are much more specialized. So even in hematology, of course, I mean, I think I'm speaking from the perspective of a specialist hospital. So we have people who specialize in MPN, we have people who are plasma cell people, etc. I think, I mean, most hospitals will have a hematologist who will see high platelets or erythrocytosis and think, okay, is this an MPN? Should we do a JAK2, etc. But I think people tend to compartmentalize these different problems. And so someone who's dealing with an MPN type thing will very rarely even think about doing a protein electrophoresis because it just doesn't enter their sphere, and I think that is if we're going to get all philosophical about it, I think the way medicine is practiced nowadays it's sad actually. I think there are many plus points of being very specialist, because if you have a problem that requires hyper specialization, then you're in the money, but if you have multi-system problems, you need someone to join the dots, and I think that is where people can fall between the cracks. And that is why Mike, I mean, we've been at pains, as Mike says, to give talks and to publish things that will be helpful, to make it easy for people to pick it up. And I have to say, the more we've done over the years, the more people do get in touch and say, oh, could this be poems? And it's always better to say, it could be, but it isn't. In fact, this week alone, we've had, two or three. Well, I gave a talk last week in the Midlands about poems, and people, they think about it. They think, oh my gosh, have I missed poems along the way? And we've had some emails, and, that is great, because if we, what I always say to people is, when we think someone may have poems, in our mind, it's like almost an emergency, a medical emergency, because every week that you delay the diagnosis usually means months of rehab for the patient at the other end, plus or minus worsening performance status, because they often have cardiorespiratory compromise and other things, which means more therapy to get them optimized, etc.
Just to clarify one particular thing with this, I guess if you're kind of in a, I don't know, MGUS clinic or something else where someone might be coming through, and you think about poems and you do a VEGF, and it's normal, is that, how unlikely does that make it? Is a sort of normal VEGF really almost incompatible with, in a patient not on steroids, is that almost incompatible with poems, or are there some kind of other things that you've got to think about apart from the steroid, that the impact of steroids here?
Mike, do you want to go for that one?
Yeah, I mean, we haven't seen, exactly with those caveats, we haven't seen many patients with poems who have a normal VEGF at presentation. I think the VEGF is definitely squashed by steroids, but otherwise it would be unusual, and the VEGF is usually very high, extremely high. I mean, at levels that you don't see with any other disease, because some other things do push the VEGF up a bit. Iron deficiency, hypoxia disorders, whether it's just COPD or sleep apnea. We've had a few patients who've had methemoglobinemia who've pushed their VEGF up as well. So there are things that make it go up, but very little keeps it suppressed.
Yes.
And so it is only in the criteria. You have to have a polyneuropathy, and you have to have a monoclonal disorder, whether that's a solitary plasmacytoma, which may not be secretory, or whether it's the evidence of that secretory monoclonal disorder in the blood, for instance. So you have to have the polyneuropathy in that, and then the VEGF is not necessary. But in practical terms, it's very seldom we see a patient at presentation who hasn't got a VEGF that is exceedingly high.
Yeah. Okay. No, that's useful. So
it's a really useful biomarker. It's unusual in biomarker terms. Actually, it is not specific.
Yes.
But in the right context, it is hugely sensitive. You have to have it in the right context. You can't just say, oh, patient comes through the door, test the VEGF, is it high, got poems, is it low, hasn't got poems. It's part of the jigsaw puzzle, but it is an exceptionally good biomarker.
One point I just wanted to add was that in terms of the polyneuropathy, we have seen occasional patients with Castleman variant of poems who have very little in the way of polyneuropathy, if anything, actually. Isn't that the case, Mike?
Yeah, those Castleman's patients have almost no neuropathy at all, but they might have symptoms that sound polyneuropathic. And we've certainly had patients one particular patient who saw Mary Riley 10 years before we subsequently saw them, who I still have the letters of that interaction where the symptoms sounded like polyneuropathy, but Mary could find no evidence of it clinically or electrophysiologically, and 10 years later came back with a much more florid picture which had a clear polyneuropathy with it. So but Castleman's tends to have very little or no neuropathy. But I think, Shirley, I would say that in every case of Castleman we've seen, the VEGF is sky high.
Absolutely.
And in
In fact, recently, I was going to say recently at the meeting I was at, the team there presented their case of a patient who had everything but neuropathy, and they were really quite befuddled by that, which is fair enough because P for poems, etc. But actually, that is one scenario where you don't see much polyneuropathy. And an important point while I'm on the subject is that such patients, even though they have so-called Castleman variant, they should not be treated with drugs like siltuximab because they need POEMS treatment. That's another thing. We've seen a few patients who've, because of the Castleman finding in their nodes or whatever, they've gone on to have siltuximab, and that's actually just delayed the treatment for the neuropathy, which is antiplasma cell.
I think going back further on from that, there's always these extra little tips, aren't there? POEMS doesn't have to be POEMS in terms of all of those features.
Right.
You certainly need enough of them, and in general, you would definitely like to see a P and an M. That's pretty crucial, except in that Castleman circumstance. But in the Castleman circumstance, which would have a VEGF that was very high just because it was Castleman, you then need some of the other features in order to get at least an OEMS or a PMS, or you need at least 3 of those features to really make yourself comfortable. And of course, in the diagnostic criteria, there are many more. And actually, when you look, you actually find you've got lots more bits of the jigsaw. So you even have to think beyond the box of POEMS as an acronym. But you have to think within the whole diagnostic criteria, and there's a bit of boxing and coxing sometimes. Although actually we don't ever find that we're hammering a case into the diagnosis, that patients fit themselves nicely into the diagnosis nearly always when you look hard enough.
So it turned out that we had more to talk about with Shirley and with Mike about POEMS than I'd initially anticipated, and so we decided to make this into a part 1, and part 2 will follow shortly. So please do tune in soon for the second part of this podcast, and in the meantime do have a look at their POEMS paper on the Hemasphere website, and we'll be back with part 2 soon.
Thank you for listening to this episode of the Hemasphere podcast. All of Hemasphere's content is open access and can be found at www.hemispherejournal.com. We hope you will join us for future podcast episodes.